All right, hi everyone. Welcome to Webinar Wednesday. We're glad you could make it here. We are the North Dakota Brain Injury Network. Our information is down the bottom for you. Our website is ndbin.org, and that's our phone number there that Nicole Livedall answers, our resource facilitator. We started Webinar Wednesdays quite a few months ago, and we have 18 now. This is our I think our 19th presentation. So we started in 2019 after collaborating with the Stroke and Heart Association. We changed the definition of brain injury to allow it to be inclusive of all types of brain injury. So this was an idea that we came up with after collaborating with the Heart Association. So we are excited to have Megan with us today. She is an occupational therapist with innovative therapy solutions. Oh, I'm sorry. Trying to move you guys out of my way. With innovative therapy solutions and consulting, and she's going to talk about some ideas and techniques for managing day-to-day activities following a brain injury. So if you need to contact Megan or myself, you can email us after, or you can chat in the chat box during her presentation. My email is carly, C-A-R-L-Y, .endres, E-N-D-R-E-S, @und.edu. And then Megan will share her information with us too. So I'll let her share her screen, and you can go ahead and get started, Megan. Thanks.
All right, so I should be unmuted and good to go, right?
Yeah.
Can you hear me? Okay. Yeah. All right, so Carly said, yeah, you guys can email us and I will have my information at the end of the presentation, but definitely should probably help me navigate this too, because sometimes I can't manage all the chats and things. But if there's questions throughout, please just ask, because I don't want someone to forget something that they wanted to share or talk about or further ask questions on. So today I'm going to talk about I'm home, now what? And a little bit about why this is a topic I'm pretty passionate about. And it's going to be a broad topic because I feel with the Brain Injury Network being what it is today, it's covering people of all ages and different types of injuries. And so I just kind of want to touch on what I've seen with my business venture, where I'm doing outpatient therapy in the home. And it's been a great venture, and it's been a great experience to see good, bad, and sometimes the ugly of our healthcare system, and how we are connected at times and how we're disconnected at times, and what we can pursue for services, and how to make sure that after we get home from that more stringent care of the hospital or a SNF or rehab, what is out there for us. And I know some people have shared what they offer in our communities in some of the previous presentations, but I just kind of want to talk about it from an OT perspective and just some of my personal experiences with that. So jump in anytime you have questions or want to share a comment or anything. Today we're going to kind of talk about the overview of the healthcare continuum, and then focus more heavily on the home part of that continuum. We're going to talk about returning home and recovery. Many of you guys know, whether you're taking care of someone, you're a professional, or you've had a brain injury, that recovery doesn't stop once we leave the hospital or outpatient services or those type of things. What services to consider continuing or starting once you get home. Insurance and what to ask when seeking services. I am no expert in insurance, but I have a lot of working knowledge of different insurances and some of the benefits that they offer that aren't often blinking lights when we get our insurance that says, yes, we offer that, because as we know, insurances sometimes like to take our premiums, but not always tell us what we can get that easily. And so I'll just give you some tips and tricks of what to maybe ask when you're finding out what you can qualify for different services and things. And then community resources, which you guys hear a lot about, but always good to reiterate those, and how they can interact with each other to really build a strong support system for you once you're home or for your loved one, and then my contact information. So the healthcare continuum, I'm going to break this down as we go through this into each area or each arrow, but this is really a general basic view of the healthcare continuum. So we look at it, we're healthy, we're doing everything right, or maybe not doing everything right. And that little bubble that says health and wellness is kind of the determining factor on if we maintain our health. If our health declines, we can end up in our physician's office in an outpatient setting, the clinic or the hospital. And once we're in those settings, that's where those healthcare professionals start determining what kind of intervention we need, whether it's medication, it's therapy services, is it counseling services, etc. And then from there, you may go to outpatient services, you may discharge home, or you might go to a rehab or SNF setting. And then we progress into recovery. And recovery, to get us back to a healthy lifestyle, is really based on our ability to change our behavior or modify our environment to help meet our behavioral needs. And when I say behavior, not am I good or am I bad or am I, fighting, but behavioral in what are our habits and routines. We think about all of us, not all of us, but myself, I guess, goes through that fluctuation of I need to exercise and I need to eat better. And it's this nice wiggle wobble thing that happens, or I need to sleep more. And how can we really change our behavior so it's not just a moment in time or a month here or there, but that it carries over and we make better choices and better options for our health so we can avoid that decline again. So when we're looking at that health to decline, depending on what type of brain injury you have, we know that it could be an accident. You could get in a car accident, tip over on your bicycle, fall down the stairs and hit your head, or it could be a buildup of chronic illness, diabetes, heart disease, and you may have a stroke or an aneurysm. And this is all things that are focusing on our health and wellness. As our stress builds, I think when I worked in inpatient rehab, I would sometimes tell my clients, especially the younger ones that would have a stroke, hey, looking at your chart, it was kind of a ticking time bomb. And the point of that is not to judge the ticking time bomb part, but that we don't make another bomb after we've already suffered one explosion, okay? So I would always tell them that, hey, it's okay, I get, smoke, stress, heart disease, diabetes, they kind of build together into this, conundrum of a potential problem. But once you've had a stroke or you've had a brain injury, let's not do the same thing again, or let's try to make those changes. And that doesn't just happen in the hospital because that's a very controlled area. There's nurses, doctors, they're not giving you things, or they're not letting you go ride your bike without a helmet. They're not letting you race motocross without a helmet. They're not giving you the cigarette or the alcohol and then stressing you out with work. They've controlled your environment. But the issue is when we get home, what kind of environment are we getting back to? So we decline, we have an episode occur, and then we get into the intervention. And so while you guys are in the hospital, or if you've had a concussion and you've went into the clinic, if you've had a teen that's had a concussion, they have to go through the athletic training, go in, get cleared. What does that look like? Well, sometimes it's you need rest, go home, drink some water, sleep it off, let us know if you're having headaches. Or it can be a hospital stay where they're really trying to make sure that they're stabilizing your condition. And while you're in that setting, that's where you're going to start getting different services. So it might be occupational therapy, physical therapy, speech. You may have a neuropsychologist come in, all sorts of things. Caseworkers get involved at this point heavily, and they're trying to help be that center control of what are we going to do, where are you going to go, and how are you going to recover. And so doctors, nurses, everybody's collaborating to try to get that information out to you through one person, which is typically that caseworker. And with that being said, okay, we get through this, and okay, maybe we're going to go to outpatient, maybe we're going to get home health. There's all these things that you have to decide. And while you're in there, if you're the individual that's had the brain injury or it's your loved one, you're also stressed with that. So there's this focus of recovery and this focus of somebody always coming in going, well, how many steps do you have? And what kind of shower do you have? And do you think you can lift them? Could you show me? Well, what kind of insurance do you have? Well, could I get your insurance card? Well, do you know anything about insurance? And you're like, I don't know. And I feel like this is the point, the clinic and hospital point, where it's kind of our mental breaking point, because nobody sent us to school to learn how to navigate the healthcare system until we're living the healthcare system, which is not fair. I just met with a lady. She's not seeking services from me for OT, but I just talked to her probably 4 days in a row and was trying to figure out how to navigate getting her husband home. He's very ill, in and out of the hospital all the time, can't get him in the house. What kind of insurance? How do I get an eval at home? There's all these things. And ultimately what I see happening more times than not is people just get burnt out and they say, do whatever. And that do whatever can often bite us in the butt later on. So even this lady I met with, she was, at her wit's end, talking to multiple caseworkers, multiple insurances. She had a VA caseworker, the caseworker at the hospital, trying to navigate getting equipment into the home. And she just said, I'm just going to make do. And the scary thing for me as a therapist going into the home after that point is that, am I going to get there too late? Is there going to be a fall already? Is there going to be a burn or an injury? Or is the caregiver going to get hurt trying to move somebody around or help somebody when the environment isn't conducive to that, because they're so overwhelmed and just go with what they can make a decision on and get that person home. So that's kind of this stage where we start feeling the pressure and the chaos of the healthcare system. And then sometimes we're going to get some additional care. So if anyone's been to rehab or to a skilled nursing facility for additional rehab services, the goal there is home sweet home. Okay, let's make sure we can get you in the home. Can you walk? Can you dress yourself? Can you feed yourself? Or can somebody help you with those things? They might set you up, your caseworker at this state might set you up with some services like home health, programs like Meals on Wheels or paratransit to get you to different appointments. But to be fair to all of these different entities, their job lies within that building that they're housed in. So when you're at acute care, those caseworkers' job is to get you to the next step. It's not their job to follow up with you for, months to come, weeks to come, anything like that. It's just to say, here's all of your referrals, take this packet of paper and make sense of it when you leave here and get to your appointment, or home health should be there tomorrow. Home health has their own caseworkers or their own individuals who manage that type of a thing. But Meals on Wheels, different programs like that, you're kind of your own caseworker navigating all of that. And that can be very difficult at times. So when we are leaving this rehab facility or some sort of facility to go home, we go home with, again, another stack of papers of here's all the things I can get. But you get home and just like all of us, whether you've had a brain injury, a baby, you've had a surgery, we get that kind of treatment. You get home and everyone says, give that person time to get adjusted to home, because you've maybe been gone for weeks to months, and you get a little chill time. And then there's that expectation of, okay, we got to get back to living and back to some sort of a routine. And that is typically when a lot of those services that were given to you at these different facilities either are discontinued or they haven't followed you to your home. And there's that stress of, now what do we do? Because I got to get back to work, I got to get back to living. And that's where this behavioral modification really is going to come into play. What kind of routines and habits did I have before? Which one of those can I take with me now? What kind of support system do I need to keep having those habits and routines, whether it's your kid going to school or it's you going to a job or taking care of your children, or living retirement life and enjoying just being home with loved ones? What do you need for that? What kind of programs are available, and what type of learning can you have? So is that going to be from a therapist? Is it going to be from a social worker? Is it going to be from a support group? And how do we navigate finding all of those things? And that's kind of where the rest of this presentation continues, is how do we build that nice bubble for us to have behavioral changes in our routines or maintain good habits and routines that we had before, despite changes in our cognitive and physical abilities. I really like this quote. It says, life after brain injury, don't focus on what you can't do. Focus on what you can do. And the can't do's is what everyone else should be able to help you with. Because after I looked through the Brain Injury Network website and all of the resources that are listed there, and I've looked at Brainline and different national organizations, there are those resources out there to fill in the can't do's. It's just the navigating of those things. And so as we move on through this, returning home in recovery, what's step 1, what's step 5, what's, what can wait? The best thing to do is 1, safety, safety, safety. And that is why inpatient rehab, SNF, those type of things are trying to make sure they understand what your home is like, give them the most details. I have one client right now who cracks me up because she never lies. She always tells me the truth. And that's what I love, because she told me the other day even, well, Megan, I've been trying to do this. It's not going well, and I may have slid off my toilet riser onto the floor. Okay, good. I'm not going to judge you for that. We might laugh a little bit because she didn't get hurt, but it's not a laughing matter if she were to get hurt. And I want to know those things so that I can help her not have another incident and another incident. But the goal really is to make sure or try to eliminate most instances, right? So when I was looking at research and all these studies that are done, and 50% of people with brain injuries are a very high fall risk. Now, people with strokes are even higher. And so kind of thinking about it as inevitable instead of, well, we'll just make do, they haven't fallen yet. Chances are that person is going to fall. So probably not wait around. That's like saying, nah, I'm not going to wear my seatbelt till I get in an accident, and then we'll see how it goes. Well, that's not what we want to do, right? So returning home, the thing that is nice, and I'll talk about this with insurance, many insurances are going to cover a home evaluation. When you're in the hospital, they ask 10 million questions to you. I asked 10 million questions to my patients. How many stairs to enter? Do you have a railing? Which side is the railing on? What kind of bathroom do you have? Is it on the main floor? But I'll tell you something, until you have somebody come into your home and see what you're able to do and what your environment truly looks like, you can't get the best picture of that. And the best option, I feel like, is to just request, step 1 is to request a home eval. Whether you're able to navigate your home or you're pretty independent with things, it is covered by Medicare, it's covered by Medicaid, it's covered by Blue Cross Blue Shield. The VA will cover a home evaluation. Just get it. You never have to see that therapist again if you don't want to, but they can come in there and they may pick up on the littlest thing that could honestly save your life. And that is so important, because after you've been in the hospital a long time, you've been in the facilities or the systems or whatever you want to call it, you don't want to be in there. People are telling you when to get up, when to eat, when to take a shower. People are watching you toilet. There's always people, and you never get a full night's sleep. And so to go home and just have that person in there within the first couple weeks or a week, if you can, is great. The thing with insurance is just making sure that you, if you're the person that's had the brain injury or your loved one that's had the brain injury, is present, because that is what's going to determine if it's covered by insurance or not. The client has to be there. If not, people will do home evals. I'll do home evals if you're like, I absolutely know they're going to need modifications, but they can't be there, then that's an out-of-pocket thing. Again, much cheaper to have somebody come in and do that and look at the home and give some suggestions than paying approximately $12,000 a month for skilled nursing care. Okay, because that's kind of an alternative if we can't get people home. So step 1 would definitely be all those services that caseworker is setting you up with, but then get somebody in there for a home eval. And I'm not dinging, it's not dinging caseworkers at all. The issue typically is that OTs or people who can do home evals are tied to a brick and mortar facility, and so they're not easily able to leave outpatient settings to go to a home. It used to be way easier. When I first started as an OT, you can go, you get 2 hours, you can drive to their house, you can measure, you can look at their home and come back. They'll bring the patient there and bring the patient back. And now it's like pulling teeth to be able to do that. And so that is one benefit with mobile therapy. For what I currently do is that I can go right to the home, and that's where I provide therapy. So in the home already, there are some resources and things where social workers can come out and also check out the facilities. But that would be step one in my mind, is to make sure that your environment is not a huge barrier. Because in the hospital, the caregivers are able to be there typically with you, and your therapist and whomever are doing a great job of seeing how you do, but it's in their environment. And there's raised toilet seats, and there's grab bars, and there's wheelchairs. I talked to a lady on the phone, oh yeah, our home is accessible, I have grab bars, everything. I went in, yeah, it's kind of accessible, but it was some of the biggest fall risks I've ever seen, between rugs that weren't tacked down, tripping hazards all over, and shower in the basement down straight down steep stairs, slippery shower surfaces. And so I've been working with them, and it's been enjoyable, and she's enjoyed it too, saying, oh, I didn't think about that. It's not a ding, it's just, let's remove these things. And she actually seen her husband slip on one of the rugs that I was like, I really think we should tack that down or move it. And he slipped, and she goes, I threw that thing right in the closet. I came to her house and it was balled up in the closet. And I'm like, did you put that in the closet? And she's like, yeah, because he slipped on it. And it was just a good educational moment that, of course, we all love the decor in our homes and our furniture and those type of things. But once I kind of made it known, like, that's probably not the safest, she was more aware of it and seen it happen. And now we're to the point in her home where she's focusing on things like, can the door lock and unlock? And if her husband locks the inside door, can she get in? And she can't. And so we're looking at just changing doorknobs. But those are the little things that therapists or home modification specialists can just look at, and it is a covered service. But beyond that, so that's kind of step one for me. Of course, the home is safe. Your therapists are going to look at that, your caseworkers, but get somebody in the home just to reassess that for them, because you're providing your professionals, medical professionals, with whatever you can think of, but they can't see the home. They can't see what's on your countertops or where the fridge is in reference to the edge of an island and navigation and stuff like that. So,
hey, Megan, real quick, can I jump in and ask you a question?
You absolutely can. I like questions.
Great. So when you say case manager, are you saying like from the beginning? So when you're in the hospital at the first and you get from right there?
Yeah, and that's what's hard. So it depends on your pathway, and that's why I'm so passionate about this topic, and it's like the craziest roadmap I've ever been on. So it would depend on, if they're in acute care and go right home, it would be your acute care case manager or social worker that's tied to that facility. So if you were in Sanford Hospital and they're like, we think, Megan, we think you're good to go home and you can go to outpatient, that caseworker can refer that. But again, if let's say you go, this is just an example of from Sanford to Cobalt in Fargo. Okay, now you're going to have a whole different caseworker. And so that caseworker in acute care, their job is just to say, hey, all of this care team is referring you to Cobalt, and now we're giving you into the care of that medical team. And they have their own caseworkers who don't communicate regularly with Sanford. Okay, and when they discharge people, let's say they discharge somebody home with home health. Now home health has their own caseworkers or social workers. But at that point, whenever you're going to go home is when I would ask that caseworker for that referral. So whoever is saying, yay, we get to go home, ask for that referral so that it can get set up before. And the reason I say that is that's then on the caseworker to call and set up that referral, as opposed to you getting home and going, hey, I think I really need this. Now you have to track down who to call. And that just makes more of a more of a headache for the caregiver or the person that's had a brain injury to navigate all of those phone calls. So did that answer your question, Leslie?
It does. I just want to know, so it definitely starts in the hospital though. That case manager, you need a request from that case manager, or a case manager comes to you, or you request that and ask these questions. You know, that case manager is responsible for referring you out or giving you that information. Is that correct?
I mean, I would hope so. I can't, that's the thing that's so hard, is that that's maybe why I'm doing this too, is we have to advocate, all of us have to advocate, whether we're a professional or we're the individual that's in the hospital. Those are the questions you can ask them right away, and hopefully it gets put on their radar. So if they are sending, if that initial caseworker that you meet in, everyone meets a caseworker if you're put into acute care facility, or you should have one. I shouldn't say you always meet with them. You should request to meet with them, because what happens sometimes is they're slammed, and I 100% appreciate my caseworkers in this world, and they are very busy, but I would request, hey, could you just stop in so I can just ask some questions of you, and ask that of them right there. And therefore, if you were to go to another facility, it should be on your care plan that you have requested a home eval at some point. And they'll say, hey, that caseworker will take care of that when you go home. But it should follow that continuum of care. So it's a great question.
Thank you.
If their injury is older, would they be able to, like, say, request one now?
Absolutely, 100%. If you have not had one, you would want to call your primary care provider and request one there. And I'll get to that too, that primary care providers are so darn important, because they're kind of the hub of everything, but I would request it there. If you have good or easy access to your neurologist, you can ask them as well. It's just sometimes harder to get referrals from a neurologist because they're just more specialized and busy with other things. And so I would call your primary care provider. And all that therapist is going to do is they're going to come out and they're going to assess the home with you in it, doing what you do. And they can't say, oh, I'm not going to pay for it, or I'm going to pay for it. What comes out of that is, are we determining that there's a medical necessity for you to qualify for a grab bar or for some sort of durable medical equipment? Because there are lots, Medicaid will cover things if you have a medical necessity. They will come out and do a assessment of your home, then your home value, and provide some funding. And so VA will also provide funding if it's medically necessary. They will do the same thing, come out and kind of assess and then set you up with somebody to make those modifications. But that's the most important thing, is to have that therapist see you cognitively and physically. Can you remember to get up in time to go to work? Can you remember your medications? It can be as basic as, hey, this person needs an automated or a timed med dispenser. We're not always talking like ripping out walls and putting in a new bathroom, but we might be talking about that. But I will tell you, the important thing about this and why it's important for all of us to know this is available is Medicare actually, and Medicare's, you know, the overarching god of insurance and what we do, but Medicare actually recognized a few years ago that putting effort and energy into the home is actually saving them money, because it costs so much to go into skilled care, and it costs so much if you fall and get hurt. It costs them so much money. And so all other insurances follow suit, right? Saying, oh, well, if Medicare did all this research and found that out, we should follow suit. So it's just not out there as a general practice right now to just say, hey, home eval. And it's not general practice for outpatient facilities to allow therapists to just go. And that's what I love about what I'm doing, because I don't have an office. My office is your home, and so that's where we go. And it's just important, I guess, to me. But does that help, Leslie? I don't know if that further emphasized it, but
Yes, it did. Thank you so much.
yeah. So I think we're at step 1 of that, I believe, is home assessment. And then after that, after you get home, and you've had that home safety or home eval, it's really kind of determining who you are as the individual, or the individual you're caring for, and what were they doing before? And I say this because, again, maybe in the future, if I get to do this again, we can narrow it down to more specific populations or ages. But when I'm looking at this as a therapist and all the different brain injuries don't pick ages, right? And they don't pick stages of life. And so when I look at this, cognition, number one thing overlooked in healthcare following a TBI, number one. There was an article I just read that it's one of those that I listed there. I think it was the 2017 one, that kids, they will have a brain injury, whether it's a concussion, fall off the bike, and I think 10% or less go see their doctor within a year. Now, what's the conundrum with that is we're returning home. So we went in and they do all these tests and you come out on the normal scale, or you come out on, oh, you're fine, you passed everything. But for kids especially, they haven't finished developing. And so some of this stuff can pop up later on, a year down the road, or hitting puberty, and now we're noticing, you know, they can't concentrate, or they have headaches, or when they're reading, they're having to put their head down. And I believe in proactive versus reactive. And so with this, you know, presentation or just understanding what's in our communities, it's so important to discharge from, whether it's the clinic with a concussion or it's a pretty significant TBI for a kid, if we're talking at that right now, you need to go tell your school. You need to get that in there, and I would request a screening or an evaluation by an OT, PT, speech right away, not because you want to add work to them and not because you want to feel, you know, like you're over, like it's, oh, I'm over exaggerating what's going on. What will happen though is I would rather you would do that than get reports from teachers that your kid's lazy, your kid's sleeping all the time, he doesn't seem to care, he's not paying attention, he's all behavioral, or she's all behavioral. And it's not that. If we could have documented it earlier, hey, we screened, but Megan's doing pretty good right now, but we'll keep her on our radar, maybe we can pick up on that. And then each teacher going through that educational system knows, hey, Megan had a brain injury when she was in the 3rd grade, and she, you know, not until the reading requirements picked up did we notice that she gets headaches from reading for longer than this time, or computer use, or the lighting. And therefore, these teachers are understanding, or the educational system is understanding, as opposed to your kid's in trouble, they're not doing what they need to do. And so being proactive with that, same with work. If you've had a brain injury, you want to return to work, get that out there. I know that seems hard, but again, you can have somebody come in vocational rehab, or have someone come in and just do an eval of your workplace environment. And that's going to save you feeling like you can just do it all, and you go back to that work environment. And now you're having headaches or migraines, or loud noises are just too much, and you're having to leave and you can't perform your work duties. Vocational rehabs or occupational therapists that come in and do those things, they can look at the color of your screen. They can look at the type of font you're using to type on. What kind of ergonomics do you have? And that way, it's, again, not waiting till there's a problem and the boss is coming in saying, Megan, you take off, you know, early 3 times a week because of headaches. Do you really have headaches? And we don't want to hear that, because it's not fair, but that's what is happening to people. And then they're at a loss, and now they're scrambling to find services to say, no, I do have these issues, or, you know, these side effects from my brain injury. And if we can just change the environment, I can better do my job. Or if I can have a 20-minute break each day with no lights on, I can better perform my job. And I know that's hard to advocate, because we don't want to share our whole medical world with everyone. Like, I don't want to go tell people, you know, I fell and hit my head this summer and I think I'm fine. Well, I haven't worked I personally haven't taught all summer or presented to students all summer. I don't know how it's going to affect me. And so that's really important too. Vision is probably number 2 that is missed, I would say. We can see physical pretty easily with people, but vision and cognition are just hidden. And vision, I would request a neuro-ophthalmologist or optometrist appointment right away. Because it's not that acuity. It's not 20/20 typically. It's, do I have a visual field cut? Are you seeing double, which is going to exhaust your eyes? Are your eyes constantly moving when they're trying to focus or they can't focus? And now you suffer from chronic headaches. And sometimes what happens is if we don't do these things, again, those care providers don't interact as much. My optometrist has never talked to my primary care physician. So if I go to my primary care physician and say, hey, I've had a lot of headaches, they're going to give me a med for a lot of headaches and migraines. Okay. But in fact, if I went to my optometrist or neuro-ophthalmologist, they might be able to say, hey, you need prism glasses, or we need to actually cover one of your lenses for a while and do some vision training. And then on the other side of that, that family caregiver education driver training, there's some great resources on the North Dakota website for that, and they're all over different towns. So you can go out and get tested to see if you can go back to driving. So yeah. The other thing on here, behavioral management, there is cognitive behavioral therapy or psychotherapy. Behavioral changes are so common and they can be so minute, but to the people living with that person, they can seem so grand. I worked with people that had pretty significant brain injuries as coworkers, but I only knew them as that person, and that's easier. That was easier for me to meet them in that work environment and say, well, this is who she's always been to me. But to their loved one, you know, that's a huge change, that they're a little more rigid or a little more moody. And so getting into that right away, it can just be talking to a counselor about it initially, and they may provide you additional services. But these are things that you have to do on your own oftentimes or seek out. And that's the hardest thing, is knowing what to seek out. And I'll tell you, it never hurts to call and be told, I don't think you need this service, than to not call and miss out on getting a service. So yeah.
Megan, would a return to work like eval be covered as well, like the home ones under insurance?
Yeah, it is. There is an actual diagnostic code for it, but I believe, like for me, for OT, I think I can just bill it under like a basic code that we use. So it would just fall under like therapeutic activities. I can look into that and send that. Workman's comp, if it's a work injury, obviously is going to cover that reintegration, but and for mobile therapy, which is very interesting, and I say this again because Medicare has approved. So technically I can do outpatient therapy in the code of in the home, in the clinic, or the community. So there's a community code. So we could go out into the community and do an evaluation out there as well. So, and it's always best to, you know, for me, I like learning that. So I call all of the insurances myself to further learn what they have. And maybe someday too, that's something we could add to the web page of, here's things that you could call and ask certain insurances. You know, I know Medicaid doesn't cover self-cares, and so just knowing those things knows we can kind of navigate and move somewhere else with options for getting people services. But definitely a hard thing to navigate, again, because there's no book on navigating insurances or healthcares. It's like learning about 401ks the first big kid job you get. Okay, pick what kind of level you want. I don't know, what am I doing? And you just start Xing things off, and then your parents or someone else says, oh my gosh, you don't pick that for retirement. Okay, same with healthcare. You go, I don't know, pick, and you go with it. And then you get a bill like myself that says, I thought I already met my benefits and I thought I did this, and you're still paying money and you don't know what services you're getting. So it's tough. And I'm always available to just chat about that and help navigate it, because I just truly have a passion. It has nothing probably to do with OT, but I find that insurance can be such a help or such a barrier to people. And we pay for insurance, whether it's Medicare or private. And so helping people to get the best benefits we can from it is kind of my goal. The big fall, yep. Did somebody have a question, or was that me?
Sorry, no, that was me just saying thank you. And yes, that all makes good. Thank you.
Yeah. So fall prevention is huge, not just for OTs, but we definitely scream this. And that's where that Medicare thing came up that I was talking about. The Medicare really started finding that fall prevention is going to save them a lot of money. okay? If we can prevent falls, we prevent long-term stays, we prevent orthopedic conditions, broken hips, brain injuries, a whole slew of things. And as people age, if they fall, higher risk of breaking something, and with higher risk of breaking things, often less likely to fully recover and end up in, you know, some sort of a care facility. And so Medicare has deemed it medically necessary for somebody to get a home evaluation and look at home modifications if they're a fall risk at all. So these questions over here are just an example. Okay, if I can tell Medicare, hey, my client, you know, they had a stroke or they had a TBI last year, they have some difficulties walking, they have poor balance. If I can mark off some of these, that right there for Medicare is gonna, you know, be medically necessary as a fall prevention measure, and they will cover home assessments because they really want to avoid medical costs from falls. So the thing to help us as medical providers, or help yourself, is first go see your doctor. And when I say see your doctor, probably your primary care physician or your primary doctor that you seek. I know some people may, you know, their primary doctor may be a chiropractor or whomever, but seek them first. Tell them what's going on. Use good judgment. So until you can really get in and get some extra assessments or things done, don't go out on the ice. Don't leave your walker at home and not, you know, not use it. Don't walk around with just socks on, put tennis shoes on, those type of things. Focus on doing one task at a time, not lugging, you know, your groceries and pushing your walker and walking across ice. We have a very wonderful lady who speaks to my OT group every year, and she had a stroke in utero, I believe. And so she always tells us how she walks with her four-wheeled walker and she'll pile all of her grocery bags on her arm, and she falls on the ice every year. And I think she broke her wrist and she's broken ribs, and she's in her 30s and she finds it funny. But we're like, that's not funny. She's fallen in her shower before. And she laughs about it, but we all know that that 30-year-old body is going to become a 50, 60-year-old body, and we don't always recover the best. So if you fall into any of those, seek your medical professional and ask for a home eval or somebody to come in. Use assistive device if you have been given that. That's the thing that this particular individual always talked about. Well, it's such a pain to get out of my trunk, so I just leave it, and off she goes. Or it doesn't go through the snow the best, and off she goes and falls. And then at the end of that is make your home safer, make your work safer. If you are working or school, there are requirements that things should be accessible to a point. So looking at that with return to work, if, you know, nowadays with technology, can you work from home, which is accessible to you? Or can we make some modifications that aren't financially a burden to your workplace to help you better be successful in those environments? Services to consider. So respite care, this is a great thing. So if you have a 24-hour caregiver with you right now, there is like a caregiver program where you can look at getting respite care hours. One of my clients found that and signed up, and she gets, I think, 72 hours or 78 hours per quarter. It just depends how many hours you would get, but she has found this as a caregiver to be so helpful, to allow her to go grocery shopping, maybe go out with some friends. Well, there's a caregiver there playing games with her husband or giving him a shower, taking him outside to do activities. You can get housekeeping at times through those services or resources. Meals on Wheels is great. It's important to seek out a support group. Many of you that are on here, that's awesome, because this is kind of a nice supported educational setting, or the website is super supportive and there's resources to reach out to people. But seek out, you know, a resource of a brain injury support group or a caregiver support group if you're caring for somebody with a brain injury, because those are so important to get connected and feel that other people know or can relate to you. I can't relate. I haven't had a brain injury. I only see it through the lens of treatment, and I don't want to say, yeah, I know, I understand. because I don't. And that type of dynamic is so important for people to feel heard and validated with their concerns, and also discuss different resources that they've found or things that are helpful when recovering from a brain injury. Exercise group, great way to move those endorphins and just hopefully change some of our habits and routines if those are what led up to our brain injury. And we could all use to exercise a little more, including myself, but find that there sometimes are specialized exercise groups for people who have had strokes, who have other conditions, and so therefore that's helpful because the exercise is tailored to your needs more so than going into a general exercise setting. Or you could look at getting a personal trainer. The other resource that I like to suggest, or that I think would be great, is reaching out to area colleges that have exercise science programs or athletic training or those type of things. Our exercise science program actually offers like a mini wellness training in the fall, and they take us, typically us professors do it because they can't find people, but it's great. You go in and you get your heart checked and you do a bunch of testing. They do a mini stress test on you, and then they give you an exercise program and they meet up with you and help you go through that. So that would be a free resource. And I'm sure UND has that, or some form of that. They're always looking for participants, and they're always happy to get people who aren't the same teacher every year coming back, like myself. I've now learned how to cheat the system. I have to do so many push-ups and I have to hold a plank so long. So I don't really know if I do the full exercise program, but I do a bunch of push-ups for 3 months, and I do a bunch of planks for 3 months so I can better my score at the end of retest. But it's a great thing. Occupational therapy, speech, physical, psychology, or vocational services. Again, look into insurance or ask questions about insurance. But in the Bismarck, Mandan area, we have speech, PT, and OT as a pro bono situation if you don't qualify or you've used up all of your benefits for services and across the lifespan. So if you have Blue Cross Blue Shield and your kid has had a brain injury and you've used up all services for the year, you can contact them, the University of Mary. But make sure that you're calling these community resources, because they have so many ways to get you access to these things that I don't even know about. There's different grants, there's different programs, and it's really important that you seek them out so that, again, we're using the benefits we're given without having to just pay out of pocket for everything, because I think that's so important. Insurance and what questions to ask. I'm not going to go super far. I've went a little bit into this, but the first one I think that's very important: hospital stay versus home health versus outpatient. Okay, hospital stay and home health, they fall under the same umbrella of billing. Hospital stay and home health care services are Medicare Part A, or for Blue Cross and all those things, fall under the same umbrella, meaning that you are paying for those services whether you get them or not. So if I'm in acute care setting and I never see a physical therapist, that has been figured into my bill, and so I qualify for that service, so I'm not going to get a separate bill saying you now owe $250 to the PT department. It's all figured into that umbrella. Home health uses that same fund. Okay. The only hiccup that I run into for clients that are at home and they're trying to navigate this: home health and outpatient are not the same thing, and you can't get home health and outpatient at the same time. Home health is that you are homebound and you can't get to an outpatient facility or would further benefit from somebody in the home, but their rules and regulations are different. Not dinging them, not anything. This is their umbrella and what they've been given to work with. Home health, if things are unsafe or the client is being unsafe, they can't continue services. And so sometimes people have heard, or people tell me, well, I've had home health, and they come in for a week and they say, well, I can't do anything with the client, so I'm going to have to discharge. It's not because they're not a great therapist or they're not doing their job. It's because under what describes them, they're unable to do more. Okay, so if you are getting home health and you get discharged, it doesn't mean that you can't get other services after that or that you wouldn't qualify. And I think a lot of people feel that, well, we've been discharged, there's nothing PT, OT, or speech can do any further, and they don't seek additional services. And what happens is there's been that decline, that nice continuum that I was talking about. We've now hit that decline because we don't have that support, and that side of our pillar starts falling down. We're not getting someone checking on us. We're maybe not keeping up on our exercises. And now we see this decline, which is putting us closer to another hospital stay from a fall or a secondary condition from our brain injury. So if home health discharges, you can reach out to outpatient and say, or to your primary care physician and say, I would like an outpatient referral. Outpatient might say, nope, you're doing great. Or they might say, yeah, there's a lot we can help with. And outpatient, again, has a lot more latitude because they can work on what we call IADLs. So they can work on, can I get to the grocery store? Can I get to work? Do I know how to navigate the bus system? Do I know how to work my cell phone? Can I cook a meal? Okay, home health is home. Outpatient is everything else. So when I talk about mobile outpatient services like I provide, if you guys have been familiar with the healthcare system and you've had traditional outpatient, I 100% believe in that. And I 100% believe that mobile outpatient fills a gap. The gap of, I believe in outpatient, if we need to get out, we need some specialized equipment. You're getting, specific cares, whether it's modalities or those type of things, or it's just honestly healthy to get out and go to therapy because it's good to get out of the house. And I think that's such a benefit. But there's that time sometimes where our home still isn't safe for us, and mobile outpatient can come in and still work on, can I go get my mail? Can I cook a meal? Can I go to the grocery store? Where home health is going to say, I've done everything here in the home. I got to go. I can't keep seeing you. And that's just all of our walls that we have to stay within to qualify for services. So if does that make sense to everyone? I hope. But okay, just want to make sure, because I had a lady the other day say, we got discharged from home health, and she goes, my husband's been in the hospital 4 times. So she goes, hospital, home health, discharged, wait, hospital, home health, discharge. And so this is their 4th stay. And she was like, I didn't know there was something else, because she can't get him out of the house to get him to outpatient. And so she's just been chilling with nothing. Respite care, look into your health care or your insurances. They may cover something. Look into resources. Gym memberships. Some insurances cover, if you go to the gym so many times per month, they will cover your part of your gym membership at a reduced rate because they want to encourage preventative care. Prescription drugs, if you are not qualifying for certain prescriptions, there are really good websites. I think goodrx.com is a good one. You can go in there, you type in your drug, your prescription, and it will tell you what facilities have that and what cost it is. And so you type in your zip code and it'll say, hey, this place is selling that for this price. So for example, I have a prescription that is not covered by my insurance. It's $160 for a 3-month prescription, and I went on goodrx.com and I got it for $50 for 3 months. So it knocked off $100. There's other ones I think out there like RX Program or something, but just know that there's some of those options out there, but definitely checking with your insurance to see what they do or don't cover. Durable medical equipment, that is more than grab bars and those type of things. So you can reach out to, I don't know what's in Fargo, but here we have Great Plains, Go Universal. I don't know if New Motion in Bismarck has some durable medical equipment, but go in and they can do the background work on seeing if you qualify for that to be covered under your insurance. So if you need, a stair lift, you need a different wheelchair, a different walker, those type of things, can seek them out. again, home evals and home mods, I kind of went into a nice long tangent on that. So check with your insurance, and they probably do cover more than you think for those type of things. Community resources, touched a lot on this. I put the ndbin.org resource directory link on here because I think it's so great. I was super impressed by it. So good job to you guys. I went through like all of them. But I do honestly think that it's a great, I like that it's split up into the different areas instead of community resources and then like too many tabs. I thought it was really nice how it's organized, and it's very detailed. So it's not just, here's one, adult and aging services. That's a huge service. It covers a lot of areas, but I think that it's a nice directory for breaking that down even more into your regions. And that's so important because for the VA, for example, I don't know if I'm talking to someone in Fargo or Bismarck or where half the time because it's a statewide entity. But on the website, it's really nice that it breaks these down into the locations. So I put that on there because this North Dakota, and it's a great resource for that. If it's larger things, you know, Brainline or just Stroke Association, National Stroke, I mean, they have great resources too. It's just not going to provide you detailed community resources that you may need. And let's think about that for a minute. I'm trying to think if there's anything else I was thinking with this. Transportation, I think that's another key one. I heard that in a couple other presentations where people struggle with transportation. I hope that that gets better. I will tell you that that's something we've talked about even in our OT classroom, because we've had clients who can't get out to our free pro bono clinic or don't want to because the ride on the bus is 2 hours, an hour and a half. Within the Bismarck area. So understand that's not perfect, and hopefully that can increase. There are different organizations, and I might have to check into that more and put it or give it to Carly, but you know, there's smaller communities where people just offer up services to take people. I know my grandma does this. She is an 80-year-old woman who takes other 80-year-old women to all their appointments, but it's super helpful because they can coordinate that. And I think that's a great benefit that we could utilize, especially in some of these bigger populated areas to, hey, I'll just pick up my neighbor and take them. But it's a system where people can contact other private individuals and get to their appointments. And I know that can be such a hindrance. With Zoom and things, that's kind of been helpful. And with everyone having to catch up in the technology world, this is a nice option to connect with someone, whether you wanted to call me or Carly or anybody. I'm always available, and I like being face-to-face with people. It feels a little more intimate and like I can get to know you. So if you have questions and things, you can definitely use this option with me. But yeah, that's one thing that I think is hard in our rural communities, is to try to get transportation to some of these bigger facilities or options. Does anyone have any questions about anything and stuff that wasn't even on there?
I don't have a question. I just quickly want to say thank you so much, Megan, for choosing this industry to help others. And there's not a lot of people like you, so it's up to us and our caregivers. I mean, if we're out of it, it's up to our caregivers to help us and to reach out and be our advocate, because there's not a lot of people out there, unfortunately.
Yeah, well, thank you so much, Leslie, because that's kind of, I picked this and I'm like, I could talk about all OT, but I feel this is where being back in the community, I've always wanted to do community therapy, more community-based, and I just absolutely love it. But that is what I keep running into is clients who don't know what to do, and it's normally the caregiver. And so the cool thing is, one, I'm not scheduled for 50 minutes and I got to get to the next patient. And there's a individual who has taught me about this, and she's in Grand Forks area. And it's so neat because I can do therapy with the client, but if I need to sit down for 30 minutes with the caregiver and figure out, the other day we figured out VA benefits, and it's wonderful. And I want to hopefully encourage other people to pursue that, because we can't be lumped into, you know, a time frame sometimes, and it's just basic questions. And so not basic, but basic to some of us who live in the healthcare world to say, oh yeah, I can help you out with that. But I was not ever really given that opportunity when I was in traditional care, and I loved it. But this has been a lot more fun to have that ability to chat with people. And I'm actually we're doing a mock, it's not mock, it's real, home remodel with one of my clients, because the same thing, I've been going into their home. Her son has stage 4 brain cancer, and so we are working right now on figuring out the house. So she provided us her home to get on Facebook, and my sister's an interior design person, and we're showing how we work together to help give that package of this is what I think you should do to your home, and bringing in the design person to make it what you still love about your home, instead of just shoving grab bars everywhere and making it look like something we're not used to. So it's been fun. It's been great. But any other questions?
That is so beautiful. That is so beautiful. And I want to see that video somewhere.
Yeah, it's on, if you go, are you on Facebook, Leslie?
I sure am.
Yeah, you can follow Innovative Therapy, the name of my company. You can follow our page. And then you can also follow me or add me, Megan Dooley, on Facebook, and I have those videos on there because I have a public page. So you can go ahead and add me if you'd like. Any other questions or thoughts? And here's my information. I'm on my computer anytime I'm not with clients, it feels like. I am a teacher at University of Mary, so we kind of live on email, so I'm very used to it. So I will respond typically less than a day or less than half a day to emails of all hours and times. So if you email me at 10 p.m., I may respond. I don't know. We'll see where I'm at. Carly maybe knows how this goes, but I sometimes am like, oh, put my phone down. I don't need to be doing this. But yeah, reach out, call. I love talking on the phone, or set up a Zoom or something. If you just want to chat or ask questions, and I'm truly open to any questions. I may not always have the answer, but I think 2 heads are better than 1. So if there's something we can't tackle, we'll keep adding more heads until we figure it out and solve a problem. And then we all learn from it. I always learn something. And that's something my sister taught me too, as a interior design person. She said, I don't always get clients, even if she meets with them and educates them, but she said, I always learn something. And I think that's so important, that we're always learning. So thank you guys for joining me today, because it's been a pleasure.
Thank you. That was very informative. Yeah, you're awesome.
Oh, well, thank you.
Yeah, that was great. Anybody else have any questions before we wrap it up?
There's some chats. Oh, thank you.
Yep, thank you. Yeah.
Right.
Yeah.
All right.
Good.
Well, thanks for having me, Carly.
Thank you. Thank you. That was great. And I look forward to working with you on other projects.
Yeah. All right. Thank you, everyone. Have a great Wednesday.
Thank you. You too.
Okay. Bye.